Good morning, everybody. So almost exactly 30 years ago that I walked into this institution to begin my training in urology. So I'm really delighted to be back here almost 30 years to the day to be making this presentation on urodynamics, interpretation and reporting. I must confess, in this presentation, I am not going to be giving you the A to Z of how to interpret and how to report. I'm going to focus through 4 clinical cases on what are the pitfalls, how do you report, and perhaps through that give you all the idea that you need to practically interpret your patient's reports. You know that if you look at a urodynamic trace, you have a timeline. This is the filling cystometry part, and you can see to the third line from the top, which is in the bluish green, is the PDET line here. And in this particular patient, and this is an adult patient, I've been a little lazy here, I picked up an old slide. You can see as the bladder fills up, there's a low storage pressure. There are neither phasic rises in pressure nor a progressive rise. There's a normal capacity, age appropriate. There are normal sensations. That's the point at which the patient is given the command to void. That's the voiding pressure flow, a volitional contraction, a flow, and you can see the sphincteric activity becomes silent. Now, when you report, you're looking at storage, you're looking at voiding, you're looking at the bladder and the outlet. So essentially, whenever you plan to report, always look at all these 4 aspects of your reporting. But having said that, let me take you through the 4 cases that I talked about. And I might have glossed through some of the presentation aspects so that we bring out the urodynamic aspects. So this is a 3-year-old girl who had a lumbar myelomeningocele operated at birth. She had a T3rd cord operated to 2 years. Her parents do intermittent catheterization 5 to 6 times in a day. She has frequent leaks. There are no febrile UTIs. She has fecal incontinence. She has no hydronephrosis and increased bladder wall thickness on the ultrasound scan. That is her urodynamic tracing. And you can see here as the bladder fills up, there's a progressive rise in pressure. You can also see small phasic rises and falls characteristic of neurogenic detrusor overactivity. You can see here that with each of these rises and falls and at other points through the filling phase, she has multiple leaks. And with these leaks, often the pressure progress starts dropping as the leakages happen. In terms of her capacity, while the capacity looks okay, you need to look at what we call the safe capacity. And if you see the pressures in this curve, the pressures are going up well beyond 30, 35 centimeters of water. Now, while we do not have good cutoffs as to what constitutes safety, we do know what's unsafe. So if the pressures are typically 20 and more, we would consider in a child that this bladder is perhaps not safe. The other way around is not true. So the urodynamics can be used to make a diagnosis of lack of safety. But a safe bladder is a diagnosis made on the basis of the entire clinical assessment of the patient, cannot be made on the basis of the urodynamic trace. In this patient, the patient has been filled at 15 milliliters per minute. So you need to fill at an age-appropriate speed, as Mayank told you. And you can see here in the video case for this patient, this is what happens. And I hope I can get this video to behave itself. Okay, right. So you can see here in the video trace, can I scroll it? So as this bladder is filled up, you can see that she has a low volume reflux happening on the left side. I hope I can show it to you somewhere. Okay, so there's a low volume reflux on the left side, which was seen for a moment there, but there's no large volume reflux. There's no large diverticulum there. So in this patient, the patient has, in terms of the report, she's got a reduced compliance, detrusor overactivity, incontinence, normal capacity, but with uncertain voiding, a presumptive acontractility given her clinical background. She has an altered morphology, or she didn't have reflux, sorry, detrusor sphincter dyssynergia, that's why I couldn't find it. So the interpretation for this child is unsafe storage. She's got high end fill pressures, a reduced safe capacity, and there's something called the pressure specific volume, which means at what pressure you can have PSV 20, PSV 30, and so on. So the volume which is below that particular pressure, and she's got unsafe voiding because she voids by an involuntary rise in pressure with a dyssynergic outlet. So let's look at case number 2. An 11-year-old male, a vesicostomy in the neonatal period, a PUV fulguration and vesicostomy closure, on sulfenacin 5 milligrams for urgency incontinence with the symptom controlled, bilateral hydronephrosis right more than left with stable morphology and a normal EGFR. No febrile UTIs, a diary record which shows some element of overhydration. And the question here is the bladder safe? That's the urodynamic trace for this boy. Oops. And you can see here again, a normal capacity, normal storage pressures. The compliance is good. There are no phasic contractions during voiding. It appears like a obstructed bladder with a high pressure and a slow flow and a large residue. That's the patient's video study. And this is the video urodynamic snapshot, which shows the high pressure, very slow flow and a dilated prostatic urethra. The pressure goes up to about 60, but we always do what's called a video uroflow in these children. And you can see here, this is the video uroflow of the same child. And you can see here, once there's no catheter in place, then the urethral dilatation disappears. And you can see that the distal urethra is well visualized. And at this point, the patient has a good smooth flow of 10 ml per second. Given the background that this child has no difficulty in voiding, this child, whatever obstruction you saw in the pressure flow, is a tube-related artifact and is not a genuine obstruction. Are indices of obstruction useful for a child? Global experts do not agree about the utility of indices in children. Most interventions for obstruction in children are dependent on the anatomical appearance rather than demonstrating obstruction or underactivity. Pediatric indices might help, of course, for instance, in avoiding arbitrary bladder neck incisions for children who, for instance, had a PUV before. But at this point, we do not have good indices for children. So what's the verdict in this child? Normal capacity, normal compliance, no detrusor overactivity, a low-grade right VUR, not enough to confound the measurements, normal detrusor contractility, obstruction on the pressure flow is an artifact. So the voiding phase did give us one information, that the detrusor contracted well. So that obstruction, what you saw is a tube artifact, but there was a good contraction. That tells you that the detrusor muscle is good. So this child has safe storage, low pressure storage with adequate capacity, has safe voiding, normal flow, normal contractility, and presumably no obstruction. Let's look at the third child, a 7-year-old male, a PUV fulguration at 1 year, urinary frequency, urgency incontinence, no voiding difficulty, bilateral hydronephrosis, and a creatinine of 2 representing a very low EGFR, a low PVR, and that's the urodynamic trace. Once again, you can see here, normal compliance, normal age-appropriate capacity, no phasic contractions, obstructed with an abnormal flow and a large PVR. In this child, if you see the video's trace, there's a large volume reflux happening on the left side. And here, given the symptomatology with this large reflux, it is apparent that this child actually has an unsafe storage. So the fact that the compliance looks good doesn't mean anything in a child who's symptomatic, large volume reflux and upper tract dilatation. This child also had an excellent tube-free uroflow. So whatever obstruction you're seeing here, again, what you're seeing from that right part of the curve is that the contractility is good. You get a good pressure contraction, although it's not very well sustained, but it's reasonably good. But whatever obstruction you see there is not representative of what's truly happening in this child. So here, the report is the normal capacity, normal compliance, and no detrusor overactivity is misleading, actually. There's a large volume left side VUR accounting for a large part of the capacity. And on the video, you could see, I didn't show it to you for want of time, that the reflux starts happening fairly early when you're filling the bladder. And that tells you where a large proportion of the capacity actually went. There's normal detrusor contractility, and the obstruction on the pressure flow is an artifact. So here to interpret, this child who appears to have safe storage actually has an unsafe storage. He's symptomatic with confounding of pressure and volume measurements due to the large volume VUR. And what looks like an obstructed voiding is actually a safe voiding with normal flow, normal contractility, and presumably no obstruction. And so that takes me to our fourth case and final case. And this is an 11-year-old girl who has no health events in the past. She has no history of prolonged bedwetting. She had a menarche about 1 year ago. She had retention of urine about 8 months ago, following a bout of diarrhea, which occurred about a week prior to the episode of retention. We're not sure whether there was a cause and effect relationship, but that's the only thing that happened in terms of whatever you could say as a health event. She is constipated at this point. A detailed neurourological evaluation and a detailed neurological evaluation does not show any abnormality. She's had an MRI, she had nerve conduction studies, she was seen by the pediatric neurologist. All evaluation was normal. By the time she has come to us, she has used alpha blockers, she has used skeletal muscle relaxants, she has had pelvic floor relaxation therapies, she has had 100-unit botulinum toxin injection into the striated sphincter, all of which have failed. She's on intermittent catheterization for the last 8 months. The diary shows up a mild element of overhydration, and this is her urodynamic trace. You can see again, the storage part is normal, but when she tries to pass urine, all you find is straining, abdominal straining, and nothing happens. Now, it's important to remember that a diagnosis of acontractility cannot be made just by looking at the trace. So you might be doing my urodynamics and I decide I don't like your face and I'm not going to cooperate with you. You will get what appears to be acontractility, right? Or you could have what's called situational inability to void. And that's the term that we have now put forth in all the ICS documents as well, situational inability to void. So when you get something like this, be careful before you label it acontractility. It has to be clinically consistent. But in a child who's on CIC for the last 8 months, and when you do more than one cycle of testing and you consistently get this, this is likely to be clinically consistent with an acontractility. So normal compliance, normal capacity, no phasic contractions, no contraction volitional that she tries to void, and she doesn't void at all. This is a video trace, and I hope this plays. Okay, so this is her video trace, and you can see in this video cycle, she did have a little bit of void here. So you can see a small void. So let me just get the trace down to that point where that little bit of void has happened. And take a look there. You can see just a hint of proximal urethral dilatation as that void is happening. Could you see that? A slight dilatation of, let me try and get it back for you. So, a slight dilatation of the urethra as that small void happens. So see here again, you can see that there, right? Okay, so that was essentially that was the clue that she might be having a sort of a dysfunctional void. And so we did a resting urethral pressure profile for her. And although you do not have very good standardization for pediatric resting urethral pressure profiles, this 110 centimeter resting urethral pressure profile is a very high resting urethral pressure profile. You do not have good terminologies for such conditions, but the best terminology that I can offer for you at this point is what we call the high tone non-relaxing sphincter. So she has a normal capacity, normal compliance, no detrusor overactivity, failure to void clinically consistent with acontractility, a dysfunctional voiding inverted commas due to a high tone non-relaxing sphincter or the HTNRS, normal storage interpretation, abnormal voiding, presumably because of a failure to initiate the void due to a high tone non-relaxing sphincter. There are pitfalls both in adults and especially in children. More so in children because some of the communication that happens with the child becomes more problematic. Children are very anxious, more anxious than adults often, and especially at a certain age. So the very young child doesn't trouble us. So when Mayank told about the smaller children, really the 1 and 2 year olds don't trouble you at all. It's the 5 and 6 or 7 year olds who trouble you. And you can get your information with regard to bladder safety, which is the primary reason why you would do a urodynamics in a 2-year-old child at any age, right? So in terms of storage, you can see detrusor overactivity in normal children and normal adults for that matter. So any phasic contraction should be always interpreted in the light of clinical presentation. What apparently looks like a poor compliance can result from filling too fast. You should fill at perhaps about 10% of the expected capacity. 10 to 15 ml per minute is reasonable in a child, depending on the body weight. And if the pressure starts going up, you need to stop the filling and see whether you get a drift down in the pressure by a process which we call accommodation, because that would suggest to you that you're filling too fast. A reflux or diverticulum can spuriously lower the storage pressures. and hence make you feel that the compliance is better than it actually is. And it can also overestimate capacity. And here lies the importance in the pediatric patient. You must have imaging information. So although we routinely do video studies for all our children, but if you do not have that, then you must correlate with intuitively correlate with an MCUG, because without that, your study is incomplete. So very important, in the most pediatric settings, you need imaging. In terms of voiding, this has already been mentioned in a previous presentation about correcting for the voided volume, because you do not have good data as to what's the normal flow rate in children at age-associated fluorescence. Certainly, none of us have it at the tip of our tongues. So the way you can look at it is look at the voided volume, and if the flow rate is better than the square root of the max of the voided volume, and assuming that the flow pattern is okay, then this suggests a normal flow. A catheter is more likely to obstruct a pediatric urethra as compared to an adult urethra, because for the same size of catheter, the proportion of the surface cross-sectional area obstructed is more. So you can spuriously get obstruction. This synergic so-called voiding, or what appears to be a staccato voiding, can occur from a large number of other situations. It can occur because true dyssynergia, can occur because of unsupported legs, discomfort, inhibition, 10 people peering at the child. Failure to cooperate can mimic acontractility, as I mentioned, and EMG is very easily confounded. You can get spurious overactivity of the EMG, especially if it's become wet or even otherwise, and you can have a failure to reveal dyssynergia depending on how the EMG electrodes are placed. Are the electrodes of a large size? Typically, we are using adult size ECG electrodes instead of the company dedicated EMG electrodes and so on. So there are limitations to use of the EMG, and in our practice, except for the flow EMG, which still remains an important component of our evaluation in children, except for the flow EMG, we do not really rely much on the EMG for the rest of the pressure flow study. With that, I will end. Thank you very much. And if there are any questions or comments, I'd be happy to hear them.